We are fortunate to have Dr. Anant Madabhushi with us this evening to speak about artificial intelligence for precision medicine. Dr. Anant Madabhushi is a Robert Woodruff Professor of Biomedical Engineering and on faculty in the departments of Pathology, Biomedical Informatics, Urology, Radiation Oncology, Radiation and Imaging Sciences, Global Health and Computer and Information Sciences at Emory University. He is also a research career scientist at the Atlanta Veterans Administration Medical Center. He also serves as the inaugural executive director of the newly formed Emory Empathetic AI for Health Institute at Emory University. Dr. Madabhushi has authored over 500 peer-reviewed publications and more than 200 patents, either issued or pending in the areas of artificial intelligence, radiomics, medical image analysis, computer-aided diagnosis, and computer vision. He is a fellow of the American Institute of Medical and Biological Engineering, fellow of the Institute for Electrical and Electronic Engineers, didn't know there was a difference, and a fellow of the National Academy of Inventors. His work on smart imaging computers for identifying lung cancer patients who need chemotherapy was called out by Prevention Magazine as one of the top 10 medical breakthroughs of 2018. In 2019, Nature magazine hailed him as one of the 5 scientists developing offbeat and innovative approaches for cancer research. In 2019, 20, 21, and 22, Dr. Madabhushi was named to the Pathologist's Power List of 100 inspirational and influential professionals in pathology. He is also an entrepreneur, having started 3 companies, Lucid Bioimaging, Ibris Incorporated, and Picture Health. In 2019, Lucid Bioimaging attained FDA approval for one of his technologies on the use of AI for carotid plaque characterization. Dr. Madabhushi, thank you again.
Thank you. So thank you for that very flattering introduction. Real pleasure to be here, but I just want to calibrate expectations. It's all going to be downhill from here on, so just want to make sure. So I very intentionally called my talk, decided to label the talk Interpreter of Maladies, a little bit of homage to a book by Siddhartha Mukherjee called The Emperor of Maladies, which came out about a decade ago, which if you haven't read, I highly recommend. A really amazing chronology of cancer. And as I think about artificial intelligence, I think it has the potential to really be the interpreter of all maladies. And at least that's what I'm going to try to convince you over the next 45, 50 minutes and really show you applications of artificial intelligence to address a few different problems in the context of oncology, cardiovascular disease, ophthalmology. Just want to start off with my disclosure. But beyond these associations, I guess my true disclosure is the fact that I do have an account on X. So that is my Twitter handle, X handle. If any of you are on social media, if any of what I talk about today is remotely appealing, please feel free to give me a follow. All right, so just to set the stage, I think this is, I think we hear about AI being the new electricity, and there's no question that it's really having an impact across multiple different areas in so many different sectors, automobile, finance, surveillance, et cetera, but really what we're going to talk about today is the opportunity and the applications for artificial intelligence in the context of healthcare and medicine. And somebody whose writings I frequently turn to is Eric Topol. Eric Topol is actually a cardiologist himself, was previously at the Cleveland Clinic, now at Scripps, and frequently talks about the huge opportunities for artificial intelligence in medicine. So if you're not familiar with Dr. Topol's work, highly recommend looking at some of his articles and perspectives. Now, one of the questions that often comes up about artificial intelligence is, is this going to do away with jobs? Is it going to make the pathologist redundant? Is it going to make the radiologist redundant? And this is a very sobering piece of data because this actually shows on a global basis the actual expertise in pathology. And when you look at this map, it really shows you the significant paucity of pathology expertise that exists on a global basis. When we think about artificial intelligence taking away jobs, it's actually quite a contrary picture. We don't have enough sufficient expertise, and that's exactly the need that artificial intelligence can fill. If you look at countries, for instance, in Africa, Botswana is one example that is worth quoting, a country with over 2 million people, but one pathologist for the entire country. So, more than putting people out of business, I think the opportunity is decision support to really help augment and add and empower the physician's portfolio. So now the question is, what is AI and what AI? And I guess over the last couple of years since ChatGPT came out, I think we've conflated all AI, or a lot of people have conflated all AI with ChatGPT. And it's important to understand that ChatGPT is only one specific avatar or version of AI or machine learning, right? Essentially, this specific model of AI uses something called neural networks, right? And neural networks, in fact, have been around for a very long time. They've been around for over 60 years. But what has happened over the last perhaps decade or so is the fact that because of significant increase in computational power, we're able to create very sophisticated neural networks. We're able to take these neural networks, we're able to create what are called very deep neural networks. And the advantage with these networks is that when you give it data, it learns from the data. It's able to memorize patterns from the data. And I'm actually showing you an example of a very early application of these neural networks or deep learning in a problem in digital pathology. This is something that we published about a decade ago, where we use these neural networks to identify cancer cells on breast cancer images. And the first time I saw this, it really knocked me off my chair. I had a student who was working on the problem. Student knew nothing about breast cancer, knew nothing about pathology, but was able to code up one of these neural networks and was able to feed it a lot of data where a pathologist had gone in and annotated cancer cells. And using that data alone, using the annotations of those cancer cells, the network was then able to learn the appearance of these cancer cells and then was able to correctly identify the presence and location of these cancer cells on new unseen images. And this was unbelievable. It was amazing because the only thing that we had provided to this machine learning AI network were annotations of the cancer cells on a few images. And using that alone, the network had learned. The question was, what exactly had the network learned? And that was one of the challenges, because with a lot of these neural networks, with these AI algorithms, while they're very compelling in their performance and the outputs that they give, the challenge is that it's very unclear as to what exactly these AI algorithms are learning. And that's why very often these are referred to as black boxes or mysterious machines, where we don't really quite understand what the AI is learning. And that's led to a bit of a crisis. Today, as we talk about AI, we have to acknowledge that there is a reproducibility crisis in science. Somebody develops an AI algorithm at one location, they maybe train it on data from a hospital in Boston, you bring it down to Atlanta, and that algorithm doesn't work. It doesn't generalize to the scans, in a different location, in a different hospital. And the big reason, one of the big reasons for this lack of reproducibility is the fact that we don't have explainability. We don't have an understanding of what the AI is actually learning. But beyond the lack of interpretation, the lack of explainability of the AI, there's another problem that a lot of us have become aware of. That is, and we were just talking about it at dinner just now, this issue of hallucinations, right? Where the AI just starts to imagine what the right answer might be. I've only been in Atlanta for a couple of years, and when I was recruited to Emory, Dr. Vikas Sukhatme was one of the folks who recruited me to Emory. He was the dean of the School of Medicine for Emory. In 2023, he decided to retire from that position. And I was at his farewell dinner, and he talked about how when he was preparing for his farewell speech, he decided to go to ChatGPT and decided to ask ChatGPT to say something about himself. So he basically typed in, "Can you tell me something about Vikas Sukhatme?" And ChatGPT sort of started giving these responses and said, Vikas Sukhatme is a nephrologist, blah, blah, blah. He's the dean, the dean of School of Medicine. And then towards the end, he very surprisingly found that ChatGPT had suggested that Dr. Sukhatme had passed away 3 years ago. So you've got this issue with these algorithms where they can actually start to hallucinate and start to provide very compelling responses that sound extremely confident but are completely erroneous, are completely wrong. And I found out, interestingly, I was trying to explain this concept of ChatGPT and hallucinations to my wife. Now, my wife works in finance, so she doesn't know very much about AI and hallucinations, but I was desperately trying to get her to understand what hallucinations mean, and I decided to do this little experiment where I was showing her ChatGPT, and I said, look, ChatGPT is multimodal, so you can actually now provide an image to ChatGPT, and then it can go in and recognize features from the image and then tell you, who the individual in the photograph was. So I did an experiment. I put a photograph of myself into ChatGPT, and it spat out this text below you. This individual is Anant Madabhushi, renowned expert in the field of medical imaging. Work is highly recognized. And so again, I was trying to explain to my wife ChatGPT, hallucinations, and it's only when I showed her this text that she looked at me, smiled, and said, darling, now I understand what you mean by ChatGPT hallucinating. It's clearly confused you for someone else. So very sobering evening because I began to realize the estimation that my wife held me in. But anyway, but more seriously, what is the opportunity here? And really what I'd like to talk to you about is the significant opportunity for artificial intelligence. And I'm going to focus primarily on imaging data to not just look at better diagnoses, which obviously is really important, but beyond diagnosis, what are the opportunities for artificial intelligence to look at routine data, to now be able to predict outcome, to be able to predict progression of disease, to predict risk of recurrence of the disease. But more than that, can we start to predict response to therapy prior to administration of the therapy? Could we look at somebody's CT scan or pathology image and start to ask, what is the kind of treatment that this patient is going to benefit from? Are they going to respond to chemotherapy? Are they going to respond to immunotherapy, for instance? And my argument is that it's really the use of artificial intelligence in developing these prognostic and predictive tools for tailoring therapy for a given patient based on their specific risk profile that will allow us to truly realize the promise of precision medicine. And why do we need to do this? We need to do this because we recognize that we do have a problem in many different diseases of overdiagnosis and overtreatment. And perhaps nowhere is this more true than in the context of prostate cancer, a disease that affects 1 in 7 men in the United States, but only 1 in 40 will die on account of it. And yet, we throw the proverbial kitchen sink at the treatment of this disease. Most men will die with prostate cancer rather than on account of it. And yet, we treat these men with radical prostatectomy, with radiation therapy, treatments and interventions that likely cause more harm than good and come with significant toxicity. And if we're being completely honest, we have to recognize that at least in the United States, we also have the issue of financial toxicity, where something like 42% of newly diagnosed cancer patients will lose their life savings, many within 1 to 2 years of that initial cancer diagnosis. And so how could artificial intelligence potentially play a role by leveraging routine data, routine pathology data, routine radiology scans to address the issue of overtreatment, overdiagnosis, but also potentially this issue of financial toxicity and reducing unnecessary costs because of ineffective treatments? And so what I'm going to talk about here primarily is the work that we're doing with AI, with machine learning, to interrogate the routine biopsies, routine pathology images like the image that you see to the right there, which is a standard pathology image, but also with routine radiology images like MRIs and CAT scans, to really try to identify features and patterns that can go above and beyond what a radiologist or a pathologist may be able to discern from the image. And so just to sort of hone in on this, I'm just giving you an example here of a chest CT scan with a large adenocarcinoma, a lung tumor. And the opportunity here is that with these AI tools, we can start to interrogate the tumor in a very, very detailed quantitative manner. We can start to look at patterns, subtle patterns within the tumor, outside the tumor. We can start to look at the tortuosity and the twistedness of the vessels associated with the tumor. And all of these provide quantitative biomarkers, quantitative measurements that we can now link to disease outcome and treatment response. And assuming this individual then had a resection of the tumor, we can now digitize that piece of tissue, that H&E image, that H&E slide, and start to interrogate that with AI. We can use AI to go in, identify the tissue areas, identify the tumor on the pathology image, and now get to the point where we can start to identify individual cancer cells within that tissue image. But more than that, we can now start to look at individual immune cells. We can look at the diversity of the immune cells, look at the diversity of the tumor and the tumor appearance. Again, a series of different quantitative features that we can mine from these biopsy images that now allow us to be able to predict outcome and treatment response. And that's what we've been doing over the last dozen years or so. And I know this is a very, very busy slide, but just wanted to give you a sense of the opportunities. Now, this is very cancer-centric, and I promise you that I will get to some non-oncologic use cases as well, but just want to give you a sense of the opportunities. To the left there are multiple different cancer types, from lung to endometrial, gynecologic, breast, rectal cancers. And in the middle there are different classes of therapies: immunotherapy, chemotherapy, trimodality, CDK4/6 inhibitors, and multiple different combinations of therapies. And in our work, we've shown that the utility of these approaches to interrogate radiology and pathology images allows us to be able to predict in advance of treatment what the outcome for these patients are going to be with these different treatments, so that you can do a better job, a more informed way of identifying what the best treatment strategy for a given patient might be. So with that, let's get into some specific use cases. I want to start off with a use case in breast cancer. Personal story here: I lost my aunt back in India over 25 years ago to breast cancer, and it was something that I decided that I had to do something about. And when I started to work in the area of breast cancer about 15 years ago, I realized that for many women with early stage breast cancer, the prognosis was actually quite good. And most women with early stage breast cancer did not actually need chemotherapy. Unfortunately, there wasn't really a good way of identifying which women were going to benefit from chemotherapy and which women could successfully avoid chemotherapy. About 20 years ago, a test called Oncotype DX came out, a gene expression test that took the tissue, ground it up, essentially looked at the profile of 21 different genes, and based on that came up with a recurrence score. So if you had a high score, essentially it meant you had more aggressive breast cancer, therefore you needed the chemotherapy. If you had a low score, it basically meant the opposite, where you had less aggressive disease and therefore could avoid the chemotherapy. So this was great. And I started to work on the problem. I realized that there was a test already. And so I was talking to my oncologist. I said, well, I guess it doesn't make sense to work on this problem because this problem's been solved. You have a test out there. He said, yes, but not quite, because for one thing, this is a tissue destructive test. So you're actually destroying the tissue. And that's valuable because we need tissue for potentially other things. B, it's a complex test because you've got to physically ship the tissue to Redwood, California, where the test is performed. And he said, C, and most importantly, the fact is that this is an expensive test. It's cost $4,000 per patient, right? And to put that in perspective, in India, the cost of chemotherapy is $1,900, right? So how do you justify a test that costs $4,000 in a country like India, where the cost of chemotherapy is half the cost of the test that's going to tell you whether you need the treatment or not? And so what we then started to do was to think about how could we use standard data, in other words, an image of a biopsy from a woman's breast cancer, to make similar predictions like the Oncotype DX test, like this expensive $4,000 test. And so we started to look at this problem. This is work we published a couple of years ago, where we looked at women with significantly poor prognosis, that's on the left, and women with much better prognosis, with longer-term survival here on the right. But one of the things I talked about earlier was the lack of interpretability, the lack of explainability of the AI. And that's something that we were very cognizant of. We wanted to develop tools that were going to be more transparent, more interpretable. And so the idea that we came up with was if we could look at these H&E images, but specifically decided to focus on collagen. Now, collagen is a protein that we're aware of is implicated in the prognosis of a number of different cancers. And here, using AI, we were able to identify the tumor nests. We were able to identify in blue the collagen fibers. And having done that, we were able to ascribe a directionality or a vector to those individual collagen fibers. So those arrows that you see there represent the direction of the collagen that we were identifying with the AI. And one of the things that we realized when we looked at these images was in women that tended to have short-term survival, the collagen fibers were all very coherently organized. They were all pointing in the same direction. But when you looked at women with long-term survival or more favorable prognosis, the arrangement was far more chaotic. And so, borrowing an idea from high school physics, namely the concept of entropy, we were able to calculate the entropy associated with the disorder of the collagen. So just very briefly, if you think about entropy, entropy captures the amount of chaos in a system. If you've got a very chaotic system, entropy is high. If you've got a very ordered or a structured system, the entropy is going to be low. And so by calculating entropy, we basically showed that if you looked at women with short-term survival, the entropy was very low. If you looked at women with better prognosis, the entropy tended to be high. And so just by looking at this single measure of order or disorder of the collagen architecture, we were able to demonstrate in over 400 women, we could separate out which women had more favorable prognosis, that's in the blue curve, versus women that had less favorable prognosis in the red curve. Again, just a very simple, interpretable, explainable feature that we were mining from routine pathology images. But we wanted to do more than that. I decided in last year, we published this article, that we wanted to see whether we could potentially supplement the Oncotype DX test. So we did this study where we looked at women who had undergone an Oncotype DX test. And over on the left were women that had been identified as having a low Oncotype DX score. So these are women where the Oncotype assay had essentially suggested that they don't need the chemotherapy. When we looked at that specific subset of women and applied our image-based assay to the images for women with the low Oncotype score, what was really interesting was we were able to identify 12% of women in the red curve who, even though Oncotype had suggested that they would not need the chemotherapy, we were finding had significantly worse prognosis, meaning that in contrary to what Oncotype was suggesting, we thought, based on the image classifier, that these women should have actually received chemotherapy. Over onto the right, when we looked at women with a high Oncotype DX score, where Oncotype was suggesting all these women needed the chemotherapy, we actually found that a significant number of women, based on the image classifier, could potentially have avoided the chemotherapy because they had much more favorable prognosis. So just to sort of give you a quick sort of summary here, essentially the image classifier was able to identify 12% women in that low Oncotype score category who probably would have benefited from chemotherapy if they had been offered that. And conversely, and perhaps more importantly, we were able to identify something like 58% of women who, according to Oncotype, should have received the chemotherapy, but our image classifier was suggesting the opposite, that they could have actually avoided the chemotherapy. So why is this important? Why does this work matter? Why am I talking about it? This is a little tongue-in-cheek, so you'll please indulge me a little bit. But just a head-to-head comparison between the molecular test and the IBRIS, which is the image-based risk score. One is the cost, right? Because you got a $4,000 molecular test. You could do this for pennies on the dollar because we're just talking about an image of a biopsy slide that can then be analyzed with artificial intelligence. You could turn this around rapidly. So imagine an oncologist in Mumbai who takes a digital image of the slide, uploads it to the cloud, the AI runs on the image and sends the results back immediately. No physical shipping of tissue, no 2-week turnaround, which is currently the status quo for these molecular-based tests. You're not destroying any of the specimens, you're digitizing the images. The accessibility is worldwide, it can be global, you're not limited to just the US. In other words, you have an inexpensive, fast, reliable, accessible prognostic breast cancer test that's priceless. For everything else, there's MasterCard. All right, what else can you do with this? So this is work that we just published last month. This is in the context of stage 0 breast cancer. One of the big questions in stage 0 breast cancer is which women should receive surgery alone and which women should receive surgery plus radiation therapy. Working with collaborators in the United Kingdom, we were able to look at a completed clinical trial back from the 90s. And by analyzing the images, the pathology images from that clinical trial from nearly 3 decades ago, we were able to find that patterns of immune cells, so the AI was used to identify immune cells from these pathology images, that the patterns of immune cells on these pathology images could actually tell us not just the risk of progression of stage 0 breast cancer to invasive ductal carcinoma or invasive breast cancer, but critically, it allowed us to predict which women were truly going to benefit from radiation therapy and which women could actually successfully avoid the radiation therapy. And one thing that I just want to point out again is the fact that we were able to leverage a completed clinical trial that was conducted over 30 years ago and sort of resuscitate that and identify these patients, of course, who've been treated a very, very long time ago. Of course, that information is clearly not useful for the patients originally on the trial, but could be very, very critical, very useful for patients being diagnosed with DCIS today. Prostate cancer is another area that we've been working on. One of the big questions in prostate cancer is which men with prostate cancer following surgery are going to need additional treatment, additional chemotherapy, for instance. This is work we published on a couple of years ago, where again, using AI, we were able to look at patterns of glands on these prostate images and showed that we were able to predict the risk of recurrence in these men following surgery. So we were able to look at the specimens, the surgical specimens, and based off that, we were able to identify which men would have a recurrence of prostate cancer after surgery and which men would not. This was a study on almost 1,000 patients from 6 different sites. One of the things that's also really interesting is the survival curves right there in the middle column, where we actually looked at margin negative patients. So these are patients when their prostates have been removed, there's no evidence of disease on the margin. So typically these are patients considered to have a more favorable prognosis. But even there you can see that the AI was able to tease out a distinctive subset of patients in the red curve that had significantly worse prognosis, significantly higher likelihood of recurrence. And so even over and above the standard clinical pathologic factors like stage and grade and lymph node status, you're finding that these AI tools can add significant additional independent prognostic and predictive value. So in the same study, we decided to go head-to-head with another genomic-based assay. I talked about Oncotype DX for the breast cancer, but we looked at something called the Decipher test, which is the equivalent test for predicting metastasis in men with prostate cancer. And when we went head-to-head between the image classifier on the left and the molecular assay on the right, we actually found that the two assays performed equivalently, even though the Decipher test cost $3,000, and of course the image classifier cost basically $3. But what was also interesting is when we combined the image classifier with two simple parameters, just the Gleason score and the preoperative prostate-specific antigen, or PSA level, we actually showed that we could almost double the performance of the genomic assay. So just the image features and two simple clinical parameters resulted in a hazard ratio that was almost twice that of the molecular-based test. And again, for pennies on the dollar compared to the molecular test in terms of cost. More similarly to the Oncotype DX data, we've also more recently shown, this was data that was presented at the American Urological Association meeting, that if you look at the Decipher low patients, again, these are patients where according to the molecular assay, these are men who have a very low risk of metastasis and potentially could be, don't need any additional treatment beyond surgery. You can see here that in this cohort of about 63 patients that were identified as Decipher low, the image features are clearly able to identify something like 60% of patients in this cohort who, even though they've been identified as low risk by the molecular assay, are in fact at elevated risk for a recurrence of the disease and therefore should be watched more vigilantly and potentially might be offered or should be offered additional therapy like chemotherapy or docetaxel. One of the other questions we've been asking about, and this is something that our group pays a lot of attention to, is around fairness of these AI tools. Are these AI tools going to work across different populations? Here in Atlanta, we've got a diversity in our patient population. There's a study that we performed and published on about 4 years ago, where we decided to look with AI at differences in the appearance of prostate cancer between Black men and white men. And so we looked at pathology images of Black men and white men with prostate cancer and found, interestingly, that there were subtle differences in the appearance of the disease within the stroma of the tumor. Now, why that's important is because we were then able to incorporate those differences into creating more population-tailored models, population-specific models, which we then showed turned out to be way more accurate in predicting recurrence in Black men compared to a population-agnostic model. In other words, when you ignored the differences and created them and used the model actually did not work in predicting risk of recurrence in Black men. But when you exploited or used these differences and created a more tailored model, a more specific model, it turned out to actually be very prognostic in Black men. And so this is one of the things that we've been paying a lot of attention to ensure that these models are not biased, that there is fairness that's intentionally introduced into these AI schemes and AI models. So I've been talking about pathology. I'm going to switch over to radiology now. This is a problem that we've been looking at in the context of brain tumors. So patients with brain tumors will get treated with chemoradiation, and following chemoradiation, they'll come back and get another MRI exam. And on that MRI exam, very often, something will flare up or show up on the scan. And the question then is this a recurrence of the tumor, or is this radiation necrosis? And we know that radiation necrosis is benign. It's an effect of the chemoradiation treatment. Unfortunately, neuro-oncologists, neuroradiologists can't really tell whether it's cancer recurrence or is it just an effect of the treatment. And so because of that, many of these patients will undergo interventional intracranial biopsies, which are invasive, expensive. And so the question we started to ask about 10 years ago is, could we look at an MRI exam and try to find patterns on the MRI exam that could distinguish which of these represents the tumor recurrence and which of these represents the radiation necrosis? And so similar to the work in collagen, we came up with an algorithm that essentially was able to look at the orientation of the pixels, specifically the gradients of the pixels. And again, borrowing the same idea of entropy, we were able to create maps like this. So essentially, these entropy maps represent the amount of heterogeneity in these images. So these red spots that you see there represent areas where the entropy was extremely high. There was a lot of heterogeneity locally. And see a lot of that on the left panel. On the right panel, on the other hand, you see the blues, which basically represent significantly lower heterogeneity, much lower entropy. And so it turns out that the left panel actually corresponds to the tumor recurrence. The right panel, on the other hand, corresponds to radiation necrosis. So even though you can't tell these apart on the original MRI scan, Now, by using this approach where we're analyzing with AI subtle patterns on these MRI scans, you're able to create a representation that makes it much easier to tell you whether this is actual recurrence of the tumor or is this just radiation necrosis. What else can we do with this? So we've taken this idea, these subtle patterns of entropy, and looked at several other problems. One of the problems that we've been working on for about a decade has been to try to distinguish benign nodules from cancerous nodules on chest CT scans. Before moving to Atlanta, I spent 10 years in Cleveland, Ohio, working at Case Western Reserve University. And I recognized there that one of the big problems in Cleveland is histoplasmosis. So the histoplasmosis can essentially create the appearance of nodules in the chest cavity. And if you get a chest CT scan for any reason, you're going to see these nodules, and they're very, very similar looking to adenocarcinomas, to lung cancers, and very difficult to tell them apart. And so we showed in this publication from about 6 years ago that looking at these entropy patterns, looking at these radiomic patterns or AI patterns, not just of the tumor, but in fact immediately around the tumor, allowed us to distinguish something that was benign from something malignant. So the lower row there actually is a granuloma, which is benign. You can see that the patterns immediately outside the nodule are lower in terms of entropy compared to the top row, which is the adenocarcinoma, where you can see there's a lot more expression of the entropy. Beyond looking at entropy and texture, one of the questions we've been asking is what else is there besides just the obvious target, right? If you're an oncologist and you tend to look at the tumor, we tend to fixate on the tumor. But the question we started to ask was, well, what if you look outside? You know, there's the tumor, but then there's stuff outside the tumor as well. And could that tell us something about tumor behavior and treatment response? This was a study we published a couple of years ago where instead of focusing on the tumor, we decided to look at the tumor-associated vasculature. We know that tumors have vasculature, have vessels associated with them. And the study we did in breast tumors, where patients were being treated with neoadjuvant anthracycline therapy, the question we were asking was, could you look at a baseline MRI scan, and could we actually predict which of these patients are going to achieve a complete pathologic response, that is, the treatment is going to work, versus those patients who are not going to achieve a pathologic response. And what we found very interestingly, when we used AI to tease out the vessels associated with the tumor, we found on the left, patients who did achieve a complete pathologic response had very smooth vessels. On the other hand, the patients who tended to not have a pathologic response had a much more twisted, convoluted, tortuous vasculature. And so here's another example of more interpretable AI rather than a black box prediction. You're making a prediction that is tethered more directly to the pathobiology of the disease. What else could you do with it? So, I've shown examples of retrospective data. Now, one of the things that we wanted to do was to really move these tools into clinical implementation. And so about 3 years ago, working with the Eastern Cooperative Oncology Group, we were able to embed these radiomic tools into an ongoing clinical trial. So this is data from an ongoing clinical trial, ECOG 5163. This is a trial of lung cancer patients being treated with immunotherapy, where we were able to embed these tools into the trial. We're analyzing patients as they're being treated on this trial. And what we're finding is that the patterns that we observed in the context of breast cancer and chemotherapy also hold in the context of lung cancer patients being treated with immunotherapy. In other words, we find that patients who tend to not respond to immunotherapy tend to have a much more twisted vasculature associated with the tumor. Patients who tend to respond to the immunotherapy tend to have a much smoother, less tortuous vasculature. And so this is still ongoing. This is still ongoing study, but we're clearly seeing a strong association between these AI-derived predictions with early response, so with the change in the tumor volume. The other question is adverse effects. Patients will be treated with chemotherapy, they'll be treated with immunotherapy. Some subset of them will develop adverse effects, adverse findings. For instance, one of the big challenges in immunotherapy is pneumonitis. A lot of these patients will develop pneumonitis. Can we predict that? And so this is data that we presented at the ASCO meeting last year, where looking at these entropy patterns from a standard CT scan, we were able to identify which patients were likely to go on to develop high-grade pneumonitis as a consequence of the treatment. And so this is really important because then it provides cues to the physician, to the oncologist, to be more vigilant and to monitor some of these patients more carefully, patients where there's a higher likelihood, as suggested by the AI, that they're going to develop pneumonitis. We did a study during COVID, like so many other people, to see if we could understand what the actual impact of the disease was. And so we did the study with about 3,400 patients across 3 different continents where we got hold of the CT scans. And essentially using what are called statistical models, we were able to learn with AI what the actual damage in the lung was because of COVID-19. And this study actually showed that we could quantify spatially in a population-based way the extent of damage and visualize the extent of damage caused by COVID. And here we compared patients who are normal controls, who had no COVID, versus patients with mild COVID-19 versus patients with severe COVID-19, and showed in this study that was published earlier this year that this approach with AI and statistical modeling allowed us to capture the extent of deformation, but also spatially localize where exactly the deformation in the lung was happening. One of the things that our group has been very interested in is opportunistic use of data, right? You get a CT scan for some reason. Could you leverage it for more than what it was originally intended for? If you get a chest CT scan for a lung cancer screening exam, could you do more with it? This is a study that we recently published on where looking at standard routine CT scans, we were able to quantify the amount of steatosis in the liver. Using a partial view of the liver, we were able to quantify the amount of hepatic fat, hepatic steatosis. And this is challenging to do off a CT scan. Typically, you look at MR spectroscopy to be able to capture the amount of steatosis. And we actually were able to show in this study that the quantification was highly accurate and was also strongly correlated with the quantification of steatosis from MR spectroscopy. But the beauty was we were doing it off a standard CT scan, and a standard CT scan that was not actually acquired for hepatic fat quantification, but we were able to leverage it to be able to make these measurements. One of the other things we decided to do was to see whether there were implications for cardiovascular outcomes. And this is a study that we've just completed. It's being written up for publication. We looked at about 47,000 patients. Again, opportunistic AI, where these were patients that had been recruited into a trial, and they had chest CT scans. So the trial was for a completely different purpose. But we were able to get hold of the chest CT scans and were able to look at a partial view of the liver. There was just a partial view of the liver. And by analyzing patterns of the liver, we were able to demonstrate in 47,000 patients that we could predict heart failure in these patients. And these are a lot of data here, but you can see here very, very compellingly, this is panel D at the bottom, the Kaplan-Meier curves, where you can see clearly that's a validation set of over 45,000 patients that have been analyzed with this AI-based approach. You can clearly see the separation between the Kaplan-Meier curves showing that we were able, with a very high confidence, able to predict the risk of heart failure based off AI analysis of a partial view of the liver on these CT scans. There's other things that you can do as well. For instance, we've been working with folks at the Cleveland Clinic where we're leveraging standard CT scans and identifying morphology and shape of pulmonary veins, of the left atrial appendage, of the left atrium, to be able to predict the risk of an arrhythmia or atrial fibrillation after, or recurrence of atrial fibrillation after ablation. And so one of the big questions in these patients, of course, after they get treated, is, are they going to have a recurrence of the disease or an arrhythmia? And with our AI-based tools, we've been able to hone in specifically on patterns of the pulmonary veins, of the left atrial appendage, of the left atrium, and shown that these features can actually predict the risk of recurrence after ablation. Cardiac echo. These are very, very noisy images. You can see that, that movie down there in the bottom. Last year, we looked at the ventricular deformation of the heart on these cardiac echo images and found that by capturing the spatiotemporal deformation of the ventricle with AI, we were able to associate these changes with major adverse cardiovascular events. So these are the Kaplan-Meier curves. Relatively small set of patients here, but you can see quite nicely that even though this test set only had 33 patients, that the unique spatiotemporal deformation profile of the ventricular wall as captured by the AI allowed us to actually predict the risk of major adverse cardiovascular events in these patients. We're looking at patients with a variety of different eye conditions, including acute diabetic macular edema, diabetic retinopathy, AMD, and looking at these entropic patterns on standard OCT scans, we're able to predict in advance of treatment which of these patients are going to respond to anti-VEGF treatments in the eye, and which of these patients are likely not to respond, and therefore are not going to benefit from these treatments. I keep coming back to this concept of opportunistic AI. You know, every one of us probably goes in to see the ophthalmologist on a yearly basis or every 2 years, and you get typically you'll get an eye exam, you'll get an image of your eye, and of course the ophthalmologist is looking at it to see whether you've got cataract or you've got potentially signs of glaucoma. And so the question we started to ask is, well, you can do all of that, and I showed you an example on the previous slide, but could you, again, leverage it in an opportunistic way to potentially ask other questions? And so one of the things that we're doing now with standard routine images of the eye is asking questions about systemic conditions, and can these features, can more interpretable features of the vasculature in the eye tell us about some of these systemic diseases? So let me just give you a few examples here as I wind up. This is work we've done very recently with the Brain Health Institute at Emory, where we analyzed something like 1,400 patients, images of the eye for 1,400 patients, and looking just at the vasculature patterns in the eye. So very similar to the work I showed with the tumors, but now we're looking at images of the eye. And looking at the retinal vasculature and looking at the twistedness of the retinal vasculature with the AI, we're actually able to identify who has Alzheimer's versus those patients who don't. And this has now been analyzed in over 1,400 patients. And this is work that's currently under review for publication. What we've also shown is that these vascular features not only are associated with Alzheimer's, they can also tell us about the risk of a cardiovascular event. And so this is data that we've now done both through the UK Biobank as well as with patients from Cleveland, where in the chronic renal insufficiency cohort, it's an ongoing clinical trial of kidney patients, that images of the eye, that the AI analysis of the retinal vasculature in the images of the eye actually can predict which patients are at elevated risk for major adverse cardiovascular events. Like I said, this has now been validated on something like 8,000 patients from the UK Biobank, which is a large cohort of patients in the UK. And then perhaps most stunningly, this is data we've literally just generated in the last couple of weeks. We're actually now able to predict from an image of the eye as to which patients are likely to develop multiple myeloma within a 10-year period. So we're able to look at a baseline image of the eye, and you can see the time axis there, over 10 years, we're actually able to predict your risk of going on to develop multiple myeloma. So that simple image of the eye can really, is really the window to so many different conditions in the rest of the body. All right, so let me conclude. So hopefully what I've conveyed is that AI is not magic. One has to be thoughtful and intentional in developing these algorithms. Computational analytics with routine imaging can really help address questions in precision medicine, specifically prognosis and predicting response to therapy. Hopefully, what I've also conveyed is that by using routinely acquired data, we can do this for relatively low cost. And that's really important, particularly in low and middle income countries. But what is really important at the end of the day to drive adoption, I would argue, is the need for interpretability, is the need for explainability. And that's why there's an intentionality with the approaches that I showed, where all of these approaches are really connected to something that is biologically tethered, more biologically plausible. So with that, I just want to thank the amazing students, trainees, postdocs, faculty colleagues that I have the pleasure and honor of working with, and just a quick shout out to the funding agencies that put food on the table. Thank you very much.
Do you think your study can help us to save the ovarian tissue before and removal, the chemotherapy and the radiation therapy after the operation of breast cancer or colon cancer in the future, which I think it can?
Yeah. So thank you for that question. I'm going to speak to I'm going to make it a little broader, not specifically to transplantation of the ovaries, but more generally to the field of transplantation. I didn't get the chance to talk about the work we're doing in the transplant space, but we're doing work in the kidney transplant space, as well as in the heart transplant space, the cardiac transplant space. And there, in fact, we've shown very recently in a publication earlier this year that we're able to predict allograft rejection based off AI analysis of endomyocardial biopsies. So by looking at, in fact, immune patterns on these endomyocardial biopsies, we're able to predict which of these patients are likely to have rejection, allograft rejection, versus those patients who are not. So I think there are huge opportunities in the transplant space. I would actually argue that AI for the transplantation space is a very primed opportunity for leveraging these technologies. And there's a lot more work to be done. So I can't speak specifically to your question about the ovaries, but in general, to the field of transplantation, I think it is very primed for the application of AI.
Time for one more question. Florence?
Thank you, Dave. Florence LaCroix, Georgia State University. From back here, when I'm looking at your figures, most of them don't show confidence intervals, except for the studies where you had a large sample size of over several thousand. So help me understand. One of your studies in particular you mentioned, the prostate study that you presented, it's still in abstract or haven't been published, but you said this that went to present to the American Urology Society had a sample size of 68. Your hazard ratio figure was very different. However, 68 is such a small sample size. Unless those figures are tight, it seems like you're concluding, you're a little aggressive on your conclusion. What were your samples? What was your confidence interval?
Great question. So let's talk about that. So every study that we do, we tend to have a multi-site validation, multi-site evaluation. And we always tend to look at a multivariable analysis. So one of the critical things with all of the data that I showed, I did talk about the multivariable analysis in the context of some of our prostate cancer work, but it is very much part of the analysis that we conduct for all the different use cases. The point I was trying to make with that Decipher study was that even though we only had 63 patients, you can start to see the value add of these AI-based approaches. We absolutely do want to increase the sample size. The cardiovascular was a great example where we had 47,000 patients. But even where we don't have a lot of samples, one of the things that we try to do is to make sure there's a plurality of sites represented in the validation set. So it's not just simply about having large numbers. Large numbers are great. I would actually argue that more than having large numbers, you really want to demonstrate the reproducibility of your tool on different sites and different institutions. And so that's very much part and parcel of how we do our analysis. We, in fact, typically have these collaborative studies with multiple different sites, multiple different institutions, and try to demonstrate that this tool is going to work on data from multiple different sites and multiple different institutions.
Thank you so much for being with us tonight.